where we'll kick off. As in previous circulations, I'm going to present the first 6 cases, then John Oxley will take over, and John Dormer is going to do the prostate cases at the end. And can I just encourage people, please, to stay with us with a few housekeeping things at the end, including quite an important announcement. So if people could stay on, that would be much appreciated. So we'll kick off with this circulation. 433 returns, which is 88% of the overall registered participants. That's about usual, or par for the course, somewhere around 90%. And we had some trainee and overseas responses as well. Exemptions remain pretty static in terms of following their introduction a few years ago, with small numbers of people exempting. No one exempted from more than 2 case types. If you do exempt from an area, that'll be flagged on your CPD cert, and you only get 2 rather than 3 CPD points for that circulation. We don't police the areas you exempt from, so that's really for you and your appraiser. So that's probably all to be said, so we can get going. So the first case was a testicular tumor. We were given some serum germ cell markers, and we were asked to specify the predominant tumor type, which did cause a bit of angst in relation to this case. So it was a small tumor, only 6 millimeters in size. And the real problem with this case was no immunohistochemistry was provided. So this is a low power shot. That's the entire tumor. A lot of it looked like this, with a tubuloglandular morphology, and the inset here shows the cytomorphology. So really kind of anaplastic looking cells with very big nucleoli, which are overlapping in areas. But there were other components to this tumor as well. There's an area here which is a bit microcystic or reticulated, and in the central area here a bit more solid, which is not as pleomorphic as the tumor on the left, which would do for some morphologically for some yolk sac tumor. This was my attempt to find an embryoid body. You'll see in the comments in a minute that somebody had queried that, but I don't think this is a real one. In fact, this embryonal carcinoma element continues out of the shot of the screen as a cystic area, so this isn't a defined body like you see in polyembryoma. But there were some other areas which had an admixture of what's probably a yolk sac component and the embryonal carcinoma elements, which would be consistent probably with a diffuse embryoma pattern. In other areas of the tumor, in addition to these 2 other elements I've mentioned already, there were some teratomatous looking glands, and although they weren't particularly no, there weren't that many of them, there were some multinucleated syncytial trophoblastic cells as well, but without the bilaminar appearance of choriocarcinoma, just with the syncytial trophoblastic cells. And there was also in the background testis a bit of germ cell neoplasia in situ as well. So we got quite a lot of comments, and we got a lot of people wanting immunohistochemistry, so 165, very high. Interestingly, only just making it into double digits is not a suitable case for EQA. And there were lots and lots of comments, which is why I've said very selected comments. This was a mixed non-seminomatous germ cell tumor, and people were quite obliging in listing the various components and even giving percentages. So this person feeling it was predominantly embryonal, about 80%, and then minor yolk sac, teratoma and syncytial trophoblastic cells. This participant obviously felt it was a bit harsh to be trying to tell the difference between embryonal and primitive yolk sac, which can be difficult to differentiate without immuno, and others going a bit further saying it's certainly not suitable without the immuno. Some of the generalists saying they'd send a tumour like this off to for central review. There were lots of suggestions of immunopanels, and probably the one that's probably most useful to differentiate yolk sac and embryonal carcinoma is OCT4, as it'll be obviously positive in the OCT4 component, but negative in the yolk sac. And then there was a question, I don't know whether Dan's dialed in, but this is why I was making reference to the diffuse embryoma and polyembryoma-like structures, and trying in my own way to try and answer that. I think from having a bit of a read about this, these are this is more sort of academic of interest. I don't think these structures actually have any practical significance or clinical significance in relation to the tumor. But if Dan, you can fire in a response there if you're around. And these were the responses that we got. So quite low agreement. Most people, or the predominant or favoured response was mixed germ cell tumour, predominantly embryonal, but there were quite a significant number that had gone for predominantly yolk sac. Now, the next two responses, embryonal carcinoma and yolk sac, these people may have, people just putting embryonal, may have put embryonal because we were asked what the predominant type is, and they may not have realised there was a mixed germ cell tumour, predominantly embryonal, and the same for the yolk sac post-pubertal type responses as well. And then we have some other, we had another one here with embryonal and teratoma. So as it's the first case, and as we didn't have any immuno, I suggest that we're, if we're going to score this case, we're going to clearly have to merge things. And I think it might not be unreasonable to merge the top 5. So anybody who's really identified embryonal or yolk sac components, notwithstanding that there were some others as well. And then the lower ones down in the list, we can probably tease these out a bit further. So we've got mixed germ cell tumour, predominantly choreo. So there were some syncytial trophoblasts, but certainly in this section, no definite, at least that I could see, of choriocarcinoma, and predominantly seminoma as a pattern also stands out. So I wonder whether you would feel that they've got the mixed germ cell tumour bit right, but not the other elements. So maybe half marks for 6, 7, and 9, and then the other offering was a pre-pubertal type yolk sac tumour, and maybe somebody pressed the wrong button there, but they're morphologically similar, although they don't, they're not associated with germ cell neoplasia in situ, but more significantly, they're really adolescent tumours. So the pre-pubertal type of yolk sac is almost always in people under 12, which clearly is not the case here. So I think we'll move on to the, is this case scoreable? If it is, we're going to have to merge things. I'm going to vote myself as well. For those of you who've just arrived and haven't logged in, if you scan the QR code here on the left, or if you enter into a web browser, the hashtag there, you'll get in. It's up to 90. We're just, if we can get over 100, that'd be great. Oh, nearly. Well done. Right. So we've got a strong majority in favour of scoring. So we'll move on to the next slide, and if people could score away. And John, did we get any comments? I was getting so excited there that we didn't.
You've dumbstruck them all.
I've dumbstruck them all. Please feel free to fire in, and I'll try and remember to stop before we actually reach the scoring slide in the next case to see if we do have any comments. So still 15 people responding, now 6 people still responding. John, have you got your scoring sheet at the ready?
Yes, boss.
Very good. Right, so we're up to 115 and there's 4 people left. I'll give it another 10 seconds and then we'll press the button. It's a raised hand there, so that that participant will have to send in a Slido query. IHC not required and site entirely suitable for specialist urology EQA.
Come on then, let's go and see what they've scored.
Let's see what we think then. So predominantly embryonal gets 1. Mixed germ cell tumor, predominantly yolk sac, is 1. Embryonal carcinoma is 1. Yolk sac post-pubertal is 1 just. Mixed embryonal and teratoma is 1. And then mixed germ cell tumor, predominantly choreo, is 0. As is predominantly seminoma, as is prepubertal type yolk sac. And teratoma post-pubertal also 0. So a little bit harsh maybe on those latter ones. I was going to say at the beginning actually that we have noticed that the online voting form is a bit more punitive. I think people find it easier to be a bit harsher when there's nobody else and you're not sticking your hand up in a room. So please do that, bear that in mind. We're not looking necessarily for just the correct answer in each case. We're looking for what's an acceptable answer based on the merits of the specific case. So we'll move on from that one. For those of you that are interested in polyembryoma and the various patterns, there's a very nice review paper here by Robert Young from a few years ago. But I don't think this is of actual clinical relevance, thankfully. Right, second case, this was a young guy of 38 who'd presented with prostatitis and azoospermia, and he'd had a resection of part of his prostate, and there was a tumor, and we were given some immuno. So PLAP, CD117, OCT34 were positive. Prostate markers were negative, lymphoid markers were negative, CD30 and MNF116 were negative. So although this is a slightly unusual tumor, that immuno profile is very suggestive, even without looking at the specimens, what it might be. So these are TUR chips, and a fairly representative area of the tumor. It's pretty solid. There's a sprinkling of inflammatory cells, so lymphocytes, some histiocytes and few plasma cells, and the inset here shows the cytomorphology. So slightly boxed off nuclei, some nice eosinophilic nucleoli, not as pleomorphic looking as the embryonal stuff in the previous case. This is another area of the tumor that's got a bit more of a prominent inflammatory infiltrate within the background, but still with recognizable tumor cells sprinkled throughout. There was some benign prostatic tissue and a bit of benign urothelium also in the specimen. We didn't get that many comments actually for this case. So 6 people saying not suitable for EQA, but not that much in the way of moans or requests for additional tissue. In terms of the comments, lots of people saying looks like seminoma, immuno is consistent with seminoma, and then making the point that metastatic seminoma wasn't an option, a specific option in the drop down. That was on purpose, as we'll come on to in a sec. And then people really discussing the differentials of why you've got seminoma in your prostate. And there's a couple of potential possibilities. One is a metastasis from a testicular primary, and the other is the possibility of primary prostatic seminoma, which is a bit hen's teeth and vanishingly rare, but does exist given the prostate's a midline structure. Some people felt that the image quality wasn't great. The section was a bit thick and blurred at the high power. Obviously rare case, and some more moans about the drop-down menu. And these were the responses. Most people favouring metastatic germ cell tumour. We didn't put options for various types of germ cell tumour to try and aid in the scoring really of this case. The next most popular answer was germ cell tumour, sort of not otherwise specified. Metastatic tumour, the next, and one assumes that people meant metastatic seminoma given the comments, and then one person went for other and said what a lot of people were saying in the comments: seminoma presumably metastatic. So obviously a rare case. Probably not many people have seen this, with everyone really saying the same thing. So I would be proposing to you that we probably merge all these as correct if we score this case. Give people that have put metastatic tumour the benefit of the doubt, given the limitations of the drop down. So have we got any comments, John? No. So we'll just move on.
No comment.
To whether people feel this is scoreable. So that's pretty unanimous. We've got everyone basically saying it is scoreable. So we've probably got enough there. We're up to 125. So metastatic germ cell tumour, John, is 1. Germ cell tumour is 1. Metastatic tumour is 1. And other seminoma metastatic is 1. So we can all pat ourselves on the back and move swiftly on. And I've put a couple of references here, just out of interest really, for the two situations here. So metastatic seminoma to the prostate, and that was actually the case in this case. Subsequently, the clinical information came to hand that there was a distant history of testicular seminoma, but you can also get primary seminomas of the prostate, which are even more rare. Right, on to number 3. So this was a cystourethrectomy specimen in a woman who presented with some lower urinary tract symptoms, and it showed a urethral tumor which was arising in a diverticulum, which is probably of relevance as we get stuck into this. And we were given not only given immuno, we were given an awful lot of immuno in this case. So the tumor was positive for PAX8, EMA, CAM 5.2, CK7, AMACA, and CA125, and it was negative for a plethora of other antibodies. The Chi67, we were told, was greater than 80%, which is of some relevance to the differentials offered. as is the fact that the tumor was negative for P63, 34 beta, and CK20. So this is a low power shot. I'm presuming this is the diverticulum with the urethra here, and there's some squamous epithelium up at the top of the section, which I'm presuming is vaginal wall. And you can see there's a bit of surface tumor here, and then some more deeply invasive tumor underneath. So this is the more surface stuff, and this is a nice tubular pattern, which should hopefully make you at least think of nephrogenic adenoma in terms of the low power morphology. In other areas, there were more papillary than tubular, so it's got a sort of tubulo-papillary surface, which again makes you think of nephrogenic adenoma or metaplasia. But in contrast to that, when you go to higher power, as you can see on the inset here, there's quite significant nuclear pleomorphism, which you shouldn't be getting in a nephrogenic adenoma. And here is the more solid, more deep down tumor, and this is clearly infiltrating or invading into the urethral wall. There's a bit of a desmoplastic reaction here, and these sort of trabeculated solid islands of tumor. In other areas, the nests were a bit larger. You can see a mitosis here in the inset, and they weren't difficult to find. And this is the nearest or the best bit that I could find where the tumor cells actually had some clear cytoplasm, but it was predominantly very eosinophilic. Not that many comments, not that many people saying not suitable for EQA, not many people wanting many other things. And there were lots of comments. So this is again is very selected, but quite nice hobnailing, which is obviously a feature that you can see in this tumor and in nephrogenic adenoma. And someone saying not very good clear cytoplasm. In fact, clear cell adenocarcinoma is probably a bit of a misnomer because it doesn't always have to be clear. Some tumors like this one can be unhelpfully quite eosinophilic. So differential diagnoses include nephrogenic metaplasia, but sorry, my thing's in the way, the MIB's too high and the tumor has an infiltrative pattern, and both of those things should make you very wary about calling this nephrogenic adenoma. Quite a few comments saying that clear cell carcinoma of either the lower urinary tract or gynae origin, and there's very significant overlap in the immuno, and essentially you really need the clinical features to tell these apart. Although it is noteworthy that this tumor was arising in a diverticulum, which is certainly a risk factor for clear cell carcinoma of the urinary tract. Some people wondering about other types of Müllerian type tumors. Somebody thinking about renal papillary carcinoma, presumably because the tumor's PAX8 positive, and quite a number of people wanted GATA3 immuno, presumably to rule out urothelial carcinoma. And these are the responses. Now, there's a lot of different types of responses, but quite good agreement, actually, in fact, very good agreement that this is, as it was submitted, a clear cell adenocarcinoma of the urinary tract. Now, these are pretty rare tumors, in fact, very rare tumors. We have had at least one in the EQA before, so maybe we are having some positive impact, because although it's rare, a very large number of people have correctly diagnosed this. If we work our way down through the other offerings, metastatic tumor, I think again maybe we have to be a bit sympathetic here, because the ovarian versions of this tumor or the gynae versions of this tumor are almost identical and really require clinical separation, or clinical and radiological separation. So people, but this was in a diverticulum, so I think it'd be harsh to call that 0, but maybe a half if people don't think it merits full marks. And adenocarcinoma NOS, the sort of a few fence sitters here, which is kind of not wrong, but it's not completely right. So maybe half marks for that. I think I'm afraid that probably should be 0, because there were the MIB and the cytology here are incompatible with what is essentially a benign tumor or neoplasm. Endometrioid carcinoma. So this is in the Mullerian camp, and are supposed to look like endometrioid tumors, which this didn't really have that typical morphology, but there's a lot of overlap. So if you're feeling kind, I think maybe we could merge that as correct, in that it's in the Mullerian type of adenocarcinoma ballpark. Skein gland carcinoma, these are the tumors that are the female equivalents of prostate cancer. Now, this didn't really, and most of them are usually cribriform or look like ductal papillary. So the morphology here isn't typical, and the immuno again wasn't quite right, although there is some overlap, and we weren't given negative prostatic markers, so maybe a half for that one as well. The TCCs, or urothelial carcinomas, we've got a splattering of different variant types, and as I said at the beginning, this tumor was P63 negative and 34 beta negative, which would be unusual for urothelial carcinoma, and it was PAX8 positive. Now, some of the upper tract urothelial carcinomas can be PAX8 positive, but not normally down in the urethra. So all of those kind of argue against TCC, even though GATA wasn't provided. Number 9 is equivalent to number 1. So if we are scoring this, we need to, I think, give 1 and 9 definitely full marks. And then adenocarcinoma urachal, not quite sure, given that we're down in the urethra where that one's come from, so probably not right. So have we got any comments, John? Has everyone fallen asleep?
No comment.
No comments. So maybe you have. Let's see now what you think and whether we should be scoring this. Right, we're over 100, so let's have a look. Yes, a few people saying no, but very strongly suggesting we should score it. So
Yeah, we've got enough, Nick.
yeah, it just says 13 are still responding, so I was just giving them. Okay, so clear cell adenocarcinoma gets 1. Metastatic tumor gets a half. Adenocarcinoma NOS gets a half. Nephrogenic adenoma gets 0. Endometrioid carcinoma gets 0. That's a bit harsh, but anyway, there we are. As does skein gland carcinoma. Well, if you put those answers, I did try to get some marks for you there. TCC, glycogen rich, 0. Glandular diff urothelial is 0. Clear cell carcinoma Mullerian origin is 1. Nested TCC is 0. large nested is 0, lymphoepithelioma is 0, urothelial, tubular and microcystic is 0, and urachal adenocarcinoma is 0. So this is just a screenshot of the new WHO and the chapter on clear cell adenocarcinoma, and one of the areas that it mentions is these tumours arising in the urethral diverticulum. So always be careful if you're dealing with one of these. Right, on to number 4. This was a two-parter. So it was a renal tumour, 8.6 centimetres, and then a supplementary question of grading, which we haven't done before. We've done staging as supplementaries, but not grading. And we were given some immuno. We were told the tumour is CA9 positive, although we weren't told the specific pattern. It's CD10 positive, EMA positive, and Vimentin positive, and it was negative for these markers, including GATA and P63. And this is a low power shot of the scan slide. This is all morphologically similar tumour up at the top, and then there was another area here which was slightly different. This is the interface, and down at the bottom right of the screen, higher power, you can see a sort of solid asana arrangement of low grade looking clear cells, and then the bulk of the tumor was different to that, and was much nastier looking, with these solid alveolated nests and rather discohesive cells falling into the alveolar lumens. And if you zoom in to the high power, although again the scanning was slightly suboptimal here, it was difficult, and the section's quite thick. I think I can convince you that there's some pretty nice rhabdoid looking cells here, with these eccentric nuclei, and then these globules of paranuclear eosinophilic material, which resemble myofibroblasts, rhabdomyoblasts, but are not, as we'll come on to in a minute. And some people also mentioned a sarcomatoid component, and I went back to the slide and had a look for that, and I couldn't see any definite areas of malignant spindle cells. There were some spindly bits, but these were more kind of myofibroblasty type cells at the edge of some of the rhabdoid tumor. But I think there may be a reason why people were suggesting sarcomatoid, and not that many comments. Only 7 people saying unsuitable for EQA. There were lots of comments here, lots and lots of people emphasizing that there was rhabdoid morphology here. This is not morphologically clear cell, but the immuno is right, and probably a rhabdoid clear cell RCC. Well, I think there was a bit in the corner that looked good for conventional clear cell in addition to the rhabdoid. I think there's a bit of sarcasm in this comment about the Vimentin, but this person also said rhabdoid transformation of clear cell to sarcoma. I would prefer rhabdoid transformation of clear cell to sarcomatoid, but this is not listed. So I think some people may have selected in the final answers sarcomatoid, as they were lumping sarcomatoid and rhabdoid together. Obviously, they're both graded in the same way, and they do often occur together in renal tumors. So that's not that unreasonable. You could say this person was going to send off for TFE3 fish, but the fact that there was a low-grade clear cell area, and we're told that the tumor's CA9 positive, both sort of go against that. So it would be surprising if that turned out to be a TFE case. A few comments about the image being blurred, but I think most people dealt with this. And then this last comment, somebody put in Desmin and Mayo D1 to confirm rhabdoid cells, but the rhabdoid cells in renal cell carcinoma are only rhabdomyoblastic like. They don't express desmin and MyoD1, so you wouldn't expect these. That would be some kind of heterologous differentiation. So just to make the point there that's not actually true. And if we go on to the responses, this was submitted as clear cell RCC with predominant high-grade rhabdoid component, and quite very high agreement here that this is clear cell renal cell carcinoma. And then there were RCC sarcomatoid. So although it wasn't easy to see the sarcomatoid bit, I wonder whether people may have lumped that as the best guess, and therefore it might be nice and merge 1 and 2 together. Again, we've got some fence sitters here just going for renal cell carcinoma NOS, but there is that low grade clear cell area, and we were given the immuno which fits with clear cell. So maybe half marks for that one. And then 4, 5, and 6, well, epithelioid angiomyolipoma, we were told this is EMA positive and HMB45 negative. So those 2 markers don't really fit with that, and morphologically, and that's probably a bit of a push. ELOC RCCs, they're CK7 positive, and we were told this is CK7 negative. So and they're almost, well, they're universally by definition CK7 positive. So it's a bit hard to rationalize this one. And then clear cell papillary, this was changed in the most recent update of the WHO from clear cell papillary to clear cell papillary renal cell tumor, rather than carcinoma, to sort of emphasize the indolent behavior of these tumors, which are by definition low grade, so ISUP grade 1 and 2, so really incompatible with sort of rhabdoid type morphology. So we certainly have enough. We're over the threshold of 75% to score the case. So hopefully you'll agree it is scoreable. So, yep, we're good to go. So we'll score away. On 25 there, so we'll get stuck in. So John, clear cell RCC is 1, sarcomatoid is 1, renal cell carcinoma NOS is 0.5, AML is 0, ELOC's 0, clear cell papillary is 0. And this is a supplementary question. So we were asked to grade, and there's really very high. So most people have recognized that there's a rhabdoid component, which is obviously ISUP grade 4, and with very high agreement here for grade 4, with a significantly lesser number going for grade 3, which is still high grade. Generally, people regard 1 and 2 as low grade and 3 and 4 as high grade. So I would wonder, or make the case, maybe we should give the grade 3s half rather than 0, as if they haven't recognized it's rhabdoid, you might not call it grade 4. But anyway, that's up to you. So hopefully we can agree to score this. So, yep, 98% agreement. So They were up in the over the hundreds anyway. So grade 1 gets 0, grade 2 gets 0, grade 3 just gets a half, and grade 4 gets 1, and not applicable gets 0. Right, number 5. This was a small biopsy. I knew this would be a bit kind of challenging, but we're very keen to get some small biopsies. Now we're using just the digital only system, which we've been quite limited with being able to do in the past with the glass slide circulation. The patient was an 80-year-old male, and importantly had previous radiotherapy for prostate cancer. And we were told, although we weren't given the immunoscan slide, that the area of interest is CD34 positive. So this is the low power of the scan slide. Most of the action is in this larger fragment. And if we go to a slightly higher power, we've got this endophytic area, most of which is comprising dilated vascular spaces with a rather papillary fibrinoid appearance lined by endothelium. So papillary endothelial hyperplasia type change. And some of the lining epithelium in these areas, the endothelium was a bit tickled up, although not frankly malignant cytologically, but certainly a bit tickled. Here you can see the end of the edge even of the endophytic area and the background urothelium, and there are a few nests of urothelial cells down a bit deeper in the lamina propria in between blood vessels with a sort of pseudo-carcinomatous type pattern. You have to be a bit careful about over-calling this as particularly the nested variant of urothelial carcinoma. The inset shows there's very mild atypia in these nests, but this is quite a nice example of so-called pseudo-carcinomatous hyperplasia, where the nests wrap around these vessels, and you can see that the papillary arrangement of the fibrin quite nicely there. And in other areas, there was quite a lot of edema, siderophages, and hemorrhage within the lamina propria, all of which are features of radiation change. And the urothelium in areas showed a bit of tickling up or atypia. This is quite a nice area to show these quite striking vacuoles in some of the umbrella cells. And there is some atypia here, but with a preserved sort of normal nuclear to cytoplasmic ratio. So a kind of reactive type of atypia, which can obviously be quite florid in some of the radiation cases, even quite a long time after radiation. 10 people saying not suitable for EQA, a few wanting more immuno, a few seek further opinions, but not enormous. And so people really mainly were in two camps here. Those that thought this was some kind of exuberant type of radiation cystitis, including some pseudocarcinomatous hyperplasia, but also people wondering about a hemangioma and papillary endothelial hyperplasia in the other camp. And some people made reference to the fact that these papillary areas looked a bit like massan tumors in the skin. So intravascular papillary endothelial hyperplasia was a comment by quite a lot of people. This comment here, I think in other areas, the CMIC fish can be useful in ruling out or in angiosarcoma or vascular type malignancy, but I'm not sure whether we use it in the bladder in this context. And you can see some people were worried about the atypia in some of the vessels and raising the possibility of angiosarcoma. So these were the offerings we got, and you can see it's quite a mixed bunch with pretty poor agreement. Although if you were to merge the top two, those people going for hemangioma, presumably because this is a localized lesion, but other people in the radiation, sort of florid example of radiation cystitis, where you can see thrombus and organization within vessels, you could theoretically merge these. Angiosarcoma, there was a significant number of people that were in that camp, but I don't think the atypia here was really as severe as you'd expect in that. And probably the best, having read a bit about this this case, probably the best label actually wasn't in the drop down, and a number of people, 7 in fact, can pat themselves on the back here with this intravascular papillary endothelial hyperplasia as probably being the best label. And I've included a reference to this at the end of this case. In fact, all those cases were associated with previous radiation therapy. And then we've got a number of others. So in summary of all of that, this is a sort of very rare, slightly esoteric case where we haven't really got great agreement. But if you were so, and we would have to merge 1 and 2 together as being correct, which people might feel is a bit of a push. So I think this is a very good educational case, but we'll see whether you think that we should be scoring it or not. Oh, John, what do we do now? Have you gone to sleep? John?
Yeah, no. Oh, there we are. It'll reset as more people think, oh, that's ridiculous, I will vote for it. So you can score it. Just.
We can now, just.
Yeah.
Please don't vote anyone else, because it could.
So you've got to merge 1 and 2. So please merge 1 and 2.
Yeah, so you need to merge 1 and 2, otherwise we're kind of right. Let's see what people. Let's see if we can get to 130. Okay. Right. So hemangioma gets 1. And hopefully radiation is going to get 1. Yeah. So let's see now. Angiosarcoma is 0. Intravascular papillary endothelial hyperplasia is 1. Atypical vascular proliferation is 0 just. No diagnosis offered is 0. Postoperative spindle cell nodule is 0. TCC, no special type, is 0. Amyloidosis is 0. Chemotherapy induced cystitis is 0. Nephrogenic adenoma is 0. Von Brunn's hyperplasia is 0. And reactive proliferative changes of the urothelium is 0. And this is the reference. It's from a few years ago now, but it's a nice paper. If you do get a funny vascular tumor, there's the very rare in here, and the inset here, it is very strikingly similar to areas of what we've looked at in that biopsy, so-called papillary endothelial hyperplasia. And as I say, all those cases were related to prior radiation therapy. Right, so AF6, this is the last one for me. This was a thankfully straightforward case, right epididymal lesion in a young male, and we were told the lesional cells were positive for HBME1, calretinin, CK56. This is a low power shot. There's a bit of benign epididymal tissue in the background, and this is the nodule. And at high power, it was a fairly uniform appearance with these tubular gland-like structures with quite prominent cytoplasmic vacuolation. At higher power, not that much in the way of nuclear atypia. There wasn't much, if any, mitotic activity or necrosis. Although at the edge of the lesion, there was a bit of an infiltrative pattern into some smooth muscle bundles. Very few comments. And these are the free text comments. This is all of them, so there weren't very many. A few people wanting to do extra immuno. This is my favorite comment of this case. In fact, my group of cases. So HBME1, is it a really new immuno that no one has, or a really old one that no one uses anymore? I think it's probably the latter. We certainly used to use that in the chest for mesothelioma a few years ago, but I think the markers have moved on a bit since then, although it still is used. There we go. We nearly all got the right answer, which is adenomatoid tumor. I didn't realize before this case, I hadn't noticed that we had this rather dodgy diagnosis, mesothelioma benign. Now, obviously, an adenomatoid tumor is a benign mesothelial proliferation. This probably isn't the terminology you should be putting in a report, as most people haven't, because you'd worry a bit that might be misinterpreted, but they are really equivalent. So I am asking you to be nice to this one person and merge 1 and 2. I think Leydig cell tumor is probably the outlier here in this case. So let me see if we all think that's scoreable. So yes, only 1% saying no, so we can score away. Right, so there we go. Adenomatoid tumor gets 1, Leydig tumor gets 0, and mesothelioma benign. Okay, you've gone for half marks for that. Perhaps not unreasonably, given that virtually everyone out of 430 people went for adenomatoid. Okay, so that's that now. I have to apologize on behalf of Dr. Oxley, who is now a keen and qualified beekeeper, because he's put in these divider slides. And I apologize if anybody has melissophobia, and I had to look that up just before the meeting. That is the phobia of bees. It comes from melissa, which is the Greek for bee. And John has I think put this in because it's not only lots of bees making honey, but if you're very eagle-eyed, as some pathologists are, you'll spot the queen there. So thanks for that, John.
You can stop sharing now.
I was getting carried away with the bees.
Now I've got to work out how to stop
Stop.
sharing.
Oh yes.
Can you see that?
I can see bees. Yes.
Excellent. So that was an hour, Nick.
I thought I was going really fast.
Yeah, not fast enough, mate. Right. Okay, that's the Queen. So you're going to have to work a bit harder for the next case, unfortunately, because this is quite a tricky case to set off. It's a 34-year-old. We're told that she had a renal mass, which she first presented during pregnancy, and they were provided with an ER and an SMA. And this is what it looked like. Unfortunately, there was a bit of chatter across the top of the slide, which didn't help. So the scanning wasn't particularly good, and also the quality of the slide wasn't fantastic. But this is what we had, a sort of polypoidy sort of appearance with an epithelial component. And within this, we had these sort of cystic areas lined by, well, for all intents and purposes, looks a bit urothelial. Possibly, maybe a bit silly, but you couldn't really appreciate that. And the stroma looked a little bit ovarian. And there's more pictures of what apparently looked like urothelial. And in the other areas at the top, there was a bit of fibrosis and hemorrhage with hemosiderin pigment. And this is the SMA, highlighting the stroma. And this is the ER. And I just like to highlight that it's saying the stromal cells, but not the epithelial component. Considering it was quite a difficult case, and I did find this the hardest case of the EQA circulation, surprisingly, only 9 people felt it was not suitable. And yet there were lots of comments fell into this sort of, this is difficult, considering a cystic nephroma, that it's not typical. And I think the epithelium was the thing which caused some angst, because we have had many of these cases before in EQA, and it's normally had a sort of a hobnail or attenuated epithelium. A lot of people were thinking that it was a bit of renal dysplasia. Biphasic. And then a lot of people were querying whether it was his endometriosis. And then some people were thinking it was a myofibroma or an AML. And these were more comments. And quite a few people wanted an HMB45 and a melanate. And then, unfortunately, we have sort of a steady stream of people complaining that they're not really up to digital reporting. And I think you can read that yourself, really. And we had a lot of differential diagnoses, and it would be very, very easy for us to have exclude this case, because we had over 16 different possible diagnoses. But unfortunately, you were quite good at getting the correct diagnosis, 88.6%. And if you include the cystic nephroma, then that's really up towards the 90%. So we will discuss the others, because there were a lot of 4% of others, and we'll discuss those in a second. So AML was tendered. They are SMA positive, and they can show ER positive staining as well. So this is not an unreasonable diagnosis to make. We weren't given the other markers to differentiate it. The cystic nephroma is basically based on how much stromal to cystic areas, and this is quite a very small cystic component. So that's why it's a mess, but they are the same thing. This is nothing like it. Hemangioma, again, we're not right with that. A leiomyoma, but we've got the epithelial component, but I suppose you could consider that maybe this is pushing into the collecting system, and that epithelium is actually the natural urothelium, but it did seem to go too far in. Metanephric adenofibroma, transitional cell carcinoma, metanephric stromal tumor, mucinous, and a solitary fibrous tumor. This has been put as differential, and we're not told of the CD34. So this is a large number of diagnoses, and then to make it worse, these are the so I just wanted to, I put this slide in because this is the WHO, and just to the epithelium can be flat, cuboidal, hobnail, but also urothelial, ciliated with a clear or eosinophilic cytoplasm. So this seemed to be the best diagnosis, and just emphasizing that AML can express ER as well as SMA. So these are the diagnoses that were offered, and they fell into three basic categories. So one was endometriosis, one was cellular angiofibroma, and one was basically they didn't know and they wanted to be educated, which is what we're here to do. And this is just a picture of an ER positive staining showing that the epithelium should have been positive. So going back to it, we now have to decide whether it's scoreable. I mean, it was 90%, so it is scoreable from the point of pure percentage but was the case acceptable? Well, only 9 people felt it wasn't. So I'm going to ask you to now vote to see if it's scoreable. I'm not going to hang around for long. Right, it is scoreable. Right, now your work really starts. So if you could score it, please. Okay, so MEST is 1, endometriosis is 0, and then we got 0. AML, that's a bit harsh.
You have to read them out, John.
Oh, sorry. So AML was 0, cystic nephroma was 1, renal interstitial tumor was 0, hemangioma 0, leiomyoma 0, metanephric adenofibroma 0, urothelial carcinoma 0, metanephric stromal tumor is 0, mucinous tubular 0, juxtaglomerular 0, amyloid 0, chronic obstructive pyelonephritis is 0, hemangioblastoma is 0, solitary fibrous tumor is 0. Did you get all those?
Yes, I think so. So 1 and 4 were merged. Everything else 0.
Yep. Okay, so the next one we're moving on to is another small bladder biopsy, 3 biopsies up to 3 millimeters. And we had 3 fragments, one with some deep muscle. And the biopsy at the bottom was slightly blurry, it has to be said, but I don't know, it looks okay. But the biopsy which was of interest was this one here, and the urothelium looked like this with bits breaking away. And on high power, you could see that the nucleoli were present. It was disorganized, nuclear pleomorphism, and certainly looked abnormal with minimal inflammation and no acute inflammation on the surface. So we were also told that, and the clinical history had a previous history of carcinoma in situ. And then these are the comments. So immunohistochemistry, 84. So that is very high. Quality of the slides, 24 didn't like it, and not suitable was 30, and people wanted more levels. I mean, that's, but the immunohistochemistry seemed to be rather high. And that's basically reflected in the other comments. And although the slide resolution was not great, I did have shown you an area where there were 5 nucleoli in one nucleus. So I thought that I agree that in one piece was not brilliant, but it was pretty good in another area, which was the area of interest. And this is the scoring. And I think that we have decided not to score. Is that right, Nick? Nick, are you there?
I am. Did we not?
I think we were going to decide it wasn't scoring, but we can.
It's only just over 75%, isn't it? And there were a lot of comments about the graininess of the image, etc. So
Yes, I think people were struggling with this without immuno. But it was clearly a case of CIS. And well, clearly, when I say clearly to me, we've got urothelial dysplasia. I think that's the people who probably would have been pushed if they'd seen a CK20, they may have gone up to CIS. Polypoid cystitis, interstitial cystitis, chemotherapy cystitis. We've got this. There's atypia, another atypia, urothelial proliferation of uncertain malignant potential, uncertain name, radiation cystitis. We weren't told of a history of radiation, granulomatous, and nephrogenic metaplasia. So, and immunohistochemistry wasn't performed by the reporting pathologist. I contacted the reporting pathologist, and this is the immunohistochemistry. You can see the P53 is pretty convincing. The CK20 certainly is not particularly full thickness, but certainly abnormal pattern, staining pattern. And the Ki67 was not brilliant either. And I just wanted to emphasize that CK20, although we use it a lot as a sort of a hand-holding thing, we must remember that, in fact, you can have negative staining for CK20 in carcinoma in situ. So we didn't score that one. We did so well on AF7. We've skipped that one. To AF9, it's a renal tumor. It's a right nephrectomy. We are provided the CK7. The CD117 was noted to be positive and negative staining for CD10 and vimentin. The macroscopic on slicing there is a 65mm brown tumor in the lower pole. You didn't really need to look at the immunohistochemistry or the slides to make the diagnosis, or did you? This is the tumor here. No central scar or anything to really help you. And it looked like this. Sort of glandular structures almost, which were falling apart. And occasionally some very large, bizarre nuclei or giant cells. And there was some vague vacuolation, but whether this was degenerative changes, poorly fixed, is unclear. But again, some nuclear enlargement. And this is the CK7 showing really just a rim of positive staining as you'd expect, and occasional positive cells, but pretty much negative. Usual mix of people, not very high in the numbers. And these are the comments, and it really is not surprising that everyone was saying, well, this could be an oncocytoma, degenerative changes. Other people were saying there are very significant overlap in this area. Second opinion always sought favor oncocytoma, but haven't seen more or all the lesion. Cytology not typical for oncocytoma, looks like. And then the differential diagnosis was between an oncocytoma and a high-grade oncocytic tumor, which is now sort of eosinophilic vacuolated tumor. As both tumors have similar immunoprofile, but I favor eosinophilic tumor, given that there's a large number of hyperchromatic atypical cells, frequent cell. I did consider high-grade eosinophilic tumor, given the prominence intracytoplasmic vacuolation, but needed more image to discard this empty. However, hot is usually positive for CD10, and this wasn't. So we were told there was CD10. Yes, and then someone was glad that they could diagnose it on an nephrectomy rather than a biopsy. And I think this really sums it up. So it's a poorly preserved specimen. We were told it was a brown tumor. It looked like an oncocytoma. It was fit, but it was these vacuoles were mimicking an EVT. And I think it's slightly, this is an interesting comment, oncocytic neoplasms in the EQA. So if you've come across this table, it's in our it's in the document folder. You can see that the hot or EVT is cathepsin K positive and CD10 positive. We wasn't provided cathepsin K, but the CD10 was negative. And but the other panel was quite similar to an oncocytoma. And these are the diagnoses you proffered. So it's definitely a scoring case because 86% thought it was an oncocytoma. Now we introduced the oncocytic renal neoplasm into the drop-down list for the renal core biopsies. And although this is technically correct, I don't think that it values a mark, but half marks, you may want to consider giving it half marks. This is the differential diagnosis. And as I discussed, this is not far off correct. We were told it was CD10 negative, which would be slightly against that, but the morphology was slightly similar to this. And we know the chromophobe was not quite right. Low-grade oncocytic tumor, we were told it's CD117 positive, and this was negative. We would have given you these comments. And then the other thing was a hybrid tumor. So I'm going to ask you if you could, were there any comments, Nick?
No, stunned everybody.
Stunned again.
Yes.
So let's see if we can score this, please. Scoreable. I don't think I'm going to wait for very long to do this. Thank you. And let's go on to doing the scoring, please. We're going to go a little bit quicker. I'm only going to wait to 100. Right. Are you ready, Nick? Oncocytoma is 1.
Yeah.
Oncocytic renal neoplasm, half marks. High-grade oncocytic tumor, 0. Chromophobe is 0. Low-grade oncocytic tumor is 0. Succinate dehydrogenase is 0. Renal cell carcinoma NOS 0. Hybrid tumor is 0. And just to give you flashbacks, 2015, we put an oncocytoma in. It had some slightly darker areas. I can't remember if it had, but 100% of people of the group managed to diagnose an oncocytoma on an H&E without immunohistochemistry. So it seems that life's got a lot more complicated since we started this EQA. Moving on to AF10. We are told this is a history of bladder cancer. It's a cystoprostatectomy specimen. And we're told there's a 35mm diameter plaque-like area at the serosal surface. This area has been sampled in section given. So there's a plaque-like area in the serosal surface. This is important because we're going to ask you to stage it later. We're told it's CK7 positive, P63 positive, CK20 negative, GATA very focal, and weak nuclear staining considered mostly negative. And this is here's the tumor. This is the serosal surface, and you can see the tumors abutting or invading the serosa. This is what the tumor looked like. Keratin pearls. And definitely squamous. And here it is invading up to the serosa. So further blocks, that goes without saying, really. And with one of these cases, we always have the same discussions. Is this a squamous cell carcinoma, or is this a pure squamous cell carcinoma, or is this a urothelial carcinoma with extensive squamous differentiation? Everyone would like to see more blocks. And given that a plaque-like area was seen in the serosa macroscope, I regard this tumor as PT3B. No conventional urothelium coming or CIS is identified in the section provided, so I've called this pure squamous. Since we're not given the luminal side of the bladder to assess urothelium, it's hard to decide whether the main tumor is urothelial carcinoma with squamous differentiation or squamous cell carcinoma of local origin or coming from elsewhere. Tumor has breached the surface, PT4. Would nice to see a GATA3, but I trust you. Difference between urothelial. The comments about GATA3 staining are unclear. It's a shame we don't have the slide to see. My diagnosis based on interpreting GATA3 is mostly negative, as implying that it blah, 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 blah. Squamous cell carcinoma, urachal primary given location, not on drop-down list. Or should urachal carcinoma NOS be chosen? So this is probably a scoring case. We've got 83% saying squamous cell carcinoma, and then a smaller number wanting it to be urothelial carcinoma with squamous differentiation. We've introduced this category to stop the lumpers from getting scored. So this no special type now is clearly should not be used in cases where there is some differentiation. Poor differentiation, but I've shown you some nice squamous areas. And then everyone, we do get a lot of people who think this is a nested, but nested is obviously a low grade tumor and doesn't appear to be like this. So from the point of scoring, this is relatively straightforward that it can be scored. How you score these is really up to you, but I would say 1 and 2 is correct. 3 is probably not correct. 4 again is not correct, and 5 is probably again not correct. But again, I'll leave you. So let's just go on to the scorable. Again, I'm not going to wait for long because it's clearly a scorable case. Thank you. And then if you could score it for me, please. Okay, so squamous cell carcinoma is 1. Urothelial with squamous, again, is 1. No special type is 0. Poorly differentiated is 0. And nested is 0. Then we were asked to stage this tumor. And we were told that serosal surface was involved, and given that serosal plaque was macroscopically identified, staged as PT3. That's the original diagnosis. And you can see that the majority of people came in at the 3B thing. Now, PT4, this doesn't apply in uropath. This is more for colorectal tumors which involve the serosa are staged as PT4. So we don't actually use that. I mean, it seems a logical diagnosis stage to use, but it's not actually used in uropath. When we score this, which we can, you might want to be generous to 3A people who may not have realized that the clinical history, but clearly 2A and 2B were incorrect. So first of all, we're going to ask you if you want to score it. And yeah, that's scoreable. And then if you could score it, please. We're over 100. So PT2A is 0, 2B is 0, 3A is half, 3B is 1, and 4 is 0. And I'd just like to, there were a lot of comments about using GATA3 to distinguish urothelial carcinoma from SCC, but the more you use GATA3, the more you realize it's not much copper doing anything apart from confusing you. So in squamous cell carcinomas of the skin, 16% will express GATA3. So it's not a marker of urothelial versus SCC, and it shouldn't be used in that scenario. It's not reliable enough. You need to use uroplakin realistically. I'm not quite sure, Nick, you're more of an expert in this area. Is uroplakin good at doing this distinguishing, or is that just a...
Well, certainly uroplakin 2 now is more sensitive. That's been the problem with the uroplakins, that the sensitivity was quite low, but the uroplakin 2, which we do use, is quite useful. It's not positive in all the urothelial tumors, but it is positive in a significant number, and it doesn't stain, well, not with strong cytoplasmic staining squamous epithelium, and we found it quite useful in the metastatic setting, actually, for non-small cell carcinoma.
Okay, brilliant, thank you. So moving on to AF11, this is a re-resection of a bladder tumor, and it's a relatively straightforward case. We're told that the CAM 5.2 is positive with a granular dot-like. CD56 was positive, so apophysin positive, and the key 67 was greater than 90%. And really with that, again, it pretty much, you didn't really need to look at the slides. And it's cellular, smearing artifact, going into muscle, and just in a very, very small amount. I didn't really appreciate this when the first time I looked at this slide, but the comments made me have another look, and sure enough, there's a bit of squash, something which you could probably swing as urothelial. So people were pretty happy with what they were given. Clinicopathological correlation, whether it was a primary or a secondary, again, a CK20 of Merkel. I mean, yeah. So they want 95% small cell with a small 5% of high-grade urothelial. Okay, so clearly some people saw that urothelial quicker than I did. So these two added together, we're nearly at 100%. Neuroendocrine carcinoma again is correct, I suppose, and the large cell again is probably not quite right, but it's in the right ballpark, and they'd be treated exactly the same. And then metastatic tumor, that presumably that's a differential diagnosis, and I suppose you could argue that possibly right. So we need to score this, and I think it's scoreable, so I'm not going to hang around long. Thank you very much. And then could you score it, please? Oh, sorry, I was falling asleep there. Right, neuroendocrine, small cell, 1. Urothelial carcinoma with small cell, 1. Neuroendocrine carcinoma, 1. Neuroendocrine carcinoma, large cell, half. Metastatic tumor, 0. Okay, did you get those, Nick?
Yes.
Excellent. Right. I think the last case for me is AF12. We're told it's a wide local excision of penile shaft lesion, and no immunohistochemistry was performed. Unorientated lips of skin, all embedded in A1 to A3, possibly. And this is what we have: ink skin with a thickened epithelium there with lots of crap on the slide, which we always like to do, so you allow you to comment on things. And this is what it looks like. Lack of maturation, mitosis going up, clearly dysplastic. And also in the background, there's lots of nerves in the foreskin. And someone commented on this, but this is probably a normal anatomical appearance. You often get these little triglets of nerves in the foreskin, so that's probably normal. Lots of people wanted immunohistochemistry, of course. Various HPV assisted, they'd all want to do P16. P16. So according to WHO classification, block type P16 immune system is desirable for a diagnosis of HPV associated, but is not essential. Therefore, based on HPV, I find, and WHO has put this this comment in simply because it's designed for countries that don't have access to P16. And then someone used, I just want to stress that PEIN3 is not used. Undifferentiated PEIN. So the new WHO has removed the terminology undifferentiated and has separated it into PEIN, HPV associated or HPV unassociated, but has kept differentiated PEIN just to confuse everyone. And then someone was saying, well, where's the P16? I don't report this without a P16. And I think that's probably where we are now, even though it makes pretty much no difference to the patient's management. You should be doing P16 on all these cases. And we're all very, very good because HPV status unknown, HPV associated and HPV independent, you can't really split them. And it's most likely to be HPV associated, but we weren't given the P16. So I suppose this is the correct thing. But as we weren't given the P16, again, this is also correct because you can get PEIN, which is P16 negative, which looks identical to the stuff which is P16 positive. And it was called undifferentiated PEIN because I suspect that was old terminology, as I say, pre-WHO. So this is clearly scoreable. Oh, there you are. I'm not going to wait because we're going to score it all. I would score them all as correct. If I get that to work. So HPV status unknown is 1. HPV associated is 1. And there were some people who were only going to give them half marks, but HPV independent is 1 as well. And just to highlight that there is now, there's increasing number of cases. As soon as you start applying P16 to these cases, you're going to find lots of cases which have basaloid features, but are P16 negative. And here's a recent paper showing you can have basaloid features in PEIN, but they are negative. And I think it's causing a lot of confusion because this does not mean, because it's got a negative HPV, does not make it a differentiated PEIN. It's just PEIN, HPV unrelated or independent, should I say. So now I'm going to make it a bit. Oh,
just before you go, I might throw a spanner in the work for case 10, because there's a comment, although we weren't asking people to use the Q&A in Zoom, if you have a look at the Q&A and scroll to the bottom, an anonymous attendee has made a statement about the staging of your bladder tumor, which is quite interesting.
I can't actually see it. Oh, yeah.
And we should probably try and address.
I may refer to TNS up on direct invasion of the large and small intestine by the bladder tumor should be classified as PT4A. The same applies to invasion through the peritoneum covering the bladder. Interesting. Well, that's a very valid question.
So can we reset that? Can you, if you
I don't know how to do that. You'd have to reset that question. So hang on a second, but are we? Direct invasion of the
Because
large and small bladder tumor should be
because
classified as
PT4 got 0 in the.
The same applies to an invasion through the peritoneum covering the bladder. Is that actually? Why don't we just discount the staging thing and just scrap the staging, because that's only half the question.
Yeah, or we could manually adjust. There were only a few, well, it's 25. It's probably not possible to reset it in the live setting.
Should we just exclude that? What would you like to do?
We've got PT4 accepted under TNM coming in. Agree, scrap the staging question, circulate the supplement so we get it right next time. Other comments coming into Slido.
Because if you could argue that, then PT3B would be incorrect.
Yeah, exactly. So maybe we do have to scrub that.
Well, yes, if PT3B is incorrect, then it can't score.
Yeah, and we can quote the reference in the post-meeting report.
Okay, let's scrap that part of the scoring. I get educated as well, Nick.
We all do. We're all getting educated.
Anyway, so over to you, John.
Thank you. I'll just share my screen. 1 sec. There we go. Hopefully you can see that. So I'm going to do the prostate cases. So the last 3 cases. Thank you for bearing with us. So AF30 is a left PZ sample from a 73-year-old male, 4 cores. There were 2 cores. The bottom core, I think it's just, can you still see that? I think it's just,
I can only see you. It's kicked you off your.
Yeah,
sharing.
Do you mind sharing it? It's kicked me off the thing. Could you share that and I'll just talk? Sorry. Because otherwise I'm going to have to shut down and restart, which will waste people's time.
Nick, why don't you share? Because then you'll be doing the next bit after him.
Okay. It's probably an easier way of doing this. How do you go? Oh, there we go. Which question is it? AF?
Yep, 12.
That one.
No, 13.
167 you want. That's it.
There we go. Yeah. Right.
Yep.
Good to go.
Sorry about that. It's just because I've got to restart my computer. So AF13, 4 cores from a 73-year-old male. Okay, Nick.
I have to be really awake now, don't I?
2 cores. The bottom core looks quite hyperchromatic, bent glandular stuff. The top core looks more unremarkable. Okay, Nick, thanks. And this is a close-up of the bottom core, which looks more dense. There's some abnormal glands back to back, traversing the core very tightly, clustered together. There's some eosinophilic nucleoli when you look at high power. It's possible some crowding of glands. You wonder if they're separable by stroma or not. Okay, thanks, Nick. There's another slightly better kind of preserved glands. Right at the top of the slide on the left, there's a possible cribriform type arrangement, some fused glands. There's another one kind of further down on the left-hand side as well, a smaller gland that looks like there's a few glands fused together as well. There's some blue mucin in some of the glands, so quite atypical glandular architecture. There's some glands traversing through the fibromuscular stroma. Again, you wonder about some fusion. That's a bit more difficult in these long kind of trails that are kind of cross-cut with a lumen cutting in and out. It's quite easy to mistake that for fused glands if you don't have levels to look through to make sure that's not the case. Okay, I think we're going on to scoring. Just a few number of comments. Some people wanted immunohistochemistry. It was only 7 out of the 400 or so that answered. Most of the comments, virtually all the comments, were about the Gleason scoring. Most people commenting that most of the tumour was predominantly Gleason pattern 4, so well-formed glands with a trace or focal elements of Gleason pattern 4, less than 5%. Most people commented. There was also some comments about a cribriform proliferation with those 2 glands that I showed you on the last slide, with comments about really how to score that. Okay, Nick. So 98.8% called it adenocarcinoma, with the rest 1.2% calling it adenocarcinoma, plus or minus an atypical introductory proliferation, which was those kind of slightly expanded cribriform glands, I suspect. But all of us called it adenocarcinoma, so I think it's a fairly easy case to score. 3+4 was called, so is it scoreable? I don't think we need to wait too long. Everyone thinks yes, that's scored so far, so that's great. So if you could score it, please. Okay, I think we've got 110 or so. So adenocarcinoma gets 1, and adenocarcinoma with AIP also gets 1. With then Gleason scoring it, so grade group 1 was favoured by 15% of participants. Grade group 2, which was the favoured by the vast majority of participants, nearly 85%. And grade group 3, which is 4+3, was favoured by 3 participants. I suspect the kind of outlier is the grade group 3, which 4+3 disease, because with a dominant pattern 4 disease, it would exclude the man from active surveillance, likely in most centres, whereas a small percentage of Gleason pattern 4 in grade group 2 wouldn't necessarily. One of the reasons why grade group percentages are now coming in as favoured for mentioning on reports. So I would kind of suggest that 1 and 2, grade groups 1 and 2 are correct, but grade group 3 is probably the outlier clinically in this, and we had a discussion about how to score Gleason grading before on the merits of the case, but also thinking about the clinical management of the patient. So 1 and 2 are probably okay to be correct, and grade group 3, but we'll see what you say. Okay, Nick. So is the supplementary scoreable? Uh, 100% yes. And if you could score it. Okay, we're over 100. So grade group 1 gets just a half, but it's close. It's perhaps slightly harsh. Okay, grade group 1 gets 0.5. Grade group 2 gets 1. And grade group 3 gets 0. Okay. Oh, this is the new. John, did you want to talk to this, as I can't control the slides anyway?
I can't remember the slides. You better ask. So this is another AI system from Error Matrix. And again, it gives you the breakdown of each of the cores of how much and things, and draws around the glands in the very pretty colors. And if you go to the next slide, it draws you the length of the tumor and show lengths of the cores, shows you some areas. And the next slide, I think, will show you the tumor. And it's can't remember if it's drawing around the grade 3 is
red was grade 3, yeah,
and
that's
then
right.
the little green ones. So you could then look at them and see if you agree with the grade 4. And then the next slide, I think, will give you the percentage. So in core 1, there was no tumor, and then they thought it was. So the people who put about 5% grade 4, it reckons it's 7.86% and not a percentage point less of grade 4. So it's 3 plus 4 and
with a minor component of 4, I think we can say. Okay, great, thank you. So AF14, part of a transperineal template prostate biopsy, 2 cores on the left posterior sector, 73-year-old man. 2 cores, bottom core looks fairly unremarkable and low power. Top core in the middle looks a bit hyperchromatic and blue, so that was the area to concentrate on. Thanks, Nick. That was the area the picture's just rotated around. So there's some glands, look a bit atrophic, a bit dark, lots of inflammatory cells around them that looks kind of ductocentric, mostly lymphocytes, but probably a few macrophages in there. There's some stromal overgrowth potentially. That's difficult to say in a prostate biopsy, but lots of stromal, not many glands. Comments, 14 people wanted immuno, a few people more levels, only 1 person thought it wasn't suitable for the EQA. Selected comments, there wasn't many, most of them talking about, just describing what was in there, mostly benign features of atrophy, focal active chronic inflammation. There was a couple of comments about need to exclude low-grade lymphoma, which was interesting. That ductocentric type inflammation that's quite mixed is usually more reactive rather than a lymphoproliferative disorder, which isn't usually ductocentric and is throughout the cores and can wipe out the glands. But there's a couple of people that wanted to exclude low-grade lymphoma, which probably relates to the ones that wanted to do immunohistochemistry. Okay, so 99.2% of us thought it was benign. There was probably 1 person that thought it was more or less than 1, probably as a differential. I thought there was a little bit of high-grade pin in there, which may be for the adenocarcinoma, as a differential. Then adenocarcinoma, which I think I couldn't see anything that looked particularly like adenocarcinoma, and ASAP was a differential diagnosis. So I think it's scoreable with nearly 100% of us wanting to call it benign. So if we could score, is the case scoreable or not? Okay, 100%. And if we could score it. Okay, we're just reaching up to 100 now, I think, just under. So 1 for benign, 0 for high-grade pin, 0 for adenocarcinoma, and 0 for ASAP. Okay, and then I think it's the supplementary question obviously is would be not applicable because we've decided it's adenocarcinoma. This is the artificial intelligence, which didn't find anything in the cause that's of suspicion. Thanks, Nick. Sorry. AF15, a patient with atypical, an abnormal MRI with a Pyrose 5 lesion, younger patient at 59, specimen from the left TZ. On this low power, there's kind of I suppose most of the cores look atypical with lots of glandular, where Nick's pointing to now is probably the most atypical area, which I think we've focused on. And you have these glomeruloid structures, so glands within glands. There's a nice one there. Gleason pattern 4 by definition. I think most of it's, and then some more well-formed glands elsewhere in the core. So not many comments, 13 people wanting some immuno. Lots of comments really again about staging and the patterns that are in here, really versus Gleason pattern 4 glomeruloid versus cribriform. Cribriform now being usually reported independently of the Gleason pattern, has a large bank of evidence now that suggests that it's an independent adverse prognostic factor within prostate cancer. Some people thought there might be a little bit of Gleason pattern 5 within the cause as well. So 96.5% of us thought it was adenocarcinoma. In fact, everyone thought it was adenocarcinoma, with a small number of people wondering whether there was intraductal carcinoma there or not. Wouldn't necessarily be important in this case because there's lots of Gleason pattern 4 in there, and some people wondering about AIP with those expanded glands as well. But all of us calling it adenocarcinoma. So it's scoreable. I would suggest that it easily is. Yes, we all agree that it's scoreable. We could score it, thank you. Okay, we're about around 100. A few more people scoring. So adenocarcinoma is 1. Adenocarcinoma with intraductal is 1. And adenocarcinoma with AIP is also 1. So everybody gets a point. Gleason group grading, it was called 4+3, so grade group 2 in the original report. That was our most preferred score of 90.5% people calling it Gleason pattern 4+3, grade group 3, and then a minor number of people thinking it was all grade group 4. I suppose the outlier of those is potentially grade group 2 with only a little bit of 3+4, because that would be potentially managed differently in that report. So that would be probably the outlier in the recent grade group. So it's probably scoreable if we agree. Okay. 98% of us thought it was scoreable. So if we could just score it on the grade groups, that'd be great. Okie dokie, let's have a look. So not applicable gets 0. Grade group 2 gets 0. Grade group 3 gets 1. Grade group 4 gets a half. Just. And grade group 5 gets 0. Okie dokie. This is just a mention about cribriform pattern disease. As I mentioned, it's going to come in as being recommended to report cribriform grade disease separately to the Gleason pattern, as it has adverse prognostic influence independently of the Gleason grading otherwise. That's the ISUP definition, really, of confluent sheet of contiguous malignant cells with multiple glandular lumina, easily seen at low power, and makes the point of there not being any stroma, mucin, or capillaries between the glands. So that central image is their kind of archetypal cribriform pattern disease. I think it's just the AI now, Nick. So the AI highlights the tumor. I think the green was grade group 4, and the red is grade group, Gleason pattern 4, and the red is Gleason pattern 3 disease this time around. And it should be, yep. And then it reckons there was tumor in all of the cores, predominantly grade group Gleason grade 4, 70-odd%. No pattern 5, and the rest of it being pattern 3. So kind of agreed with what we were thinking morphologically. And we're back to bees. Thank you, Nick, for controlling that. Apologies that it dropped out on me.
Very good. You can see and hear me again, presumably. So just very quickly, we are, I'm just giving some follow-up on a case in the last circulation, which was caused a bit of consternation. It was quite a difficult case, but a nice example of a juxtaglomerular cell tumor. And you can see these very nice rhomboid crystals on the reprocessed EM, and it was CD34 and SMA positive, as we would expect. And I actually sent this off to Lisa in Oxford to do renin immunohistochemistry, just to complete the diagnostic workup. That's the background renal parenchyma on the left there, and you can see the positive immunostain, and that's renin, really nice positive cytoplasmic staining. So definitely a juxtaglomerular cell tumor, as we suspected from the EM. And thanks, I just wanted to officially acknowledge thanks to Lisa for doing that, and maybe you might get a few referrals now, Lisa. I don't think this is going to break the bank though, because this is a pretty rare tumor. And John, are you still there?
Yeah.
Have we lost Dr. Ox? Oh, he is.
Oh,
yeah.
I'm still here. I'm still here.
Oh, you are. It's just you disappeared out the box. So quick thanks again to Lisa for that. And then the next couple of slides, or the next slide, pertains to the after we get past the bees anyway, to the
You've gone backwards.
Future of the scheme. And basically at the end of the last meeting, we got a complaint email to one of the organisers about the running of the scheme, and in accordance with the SOPs, we're required to flag this to the meeting. Now, it's not appropriate or really possible to go into the specifics of that in a forum like this, but suffice it to say it's led to a period of reflection, and John and myself have come to the conclusion. I've been involved. I actually set the scheme up in its current form back in 2005-06, and the first circulation was back in 2007, the first 2 circulations. So that's 18 odd years that I've been involved. John joined in 2010-ish. So we've been around a long time, and feel that it's probably time for some new blood. And we're proposing that we would step down as co-organisers at the end of the next circulation. But we're not going to run off completely, because we're also proposing to set up an EQA steering group or committee that we would sit on for at least 3 years. And we would be there to help and troubleshoot for people that come in. And so we're going to be looking for expressions of interest for a couple of new organisers. John has kindly agreed to give some continuity and is going to stay on, but clearly he can't run the scheme of this size on his own. So in the future, we're going to send out an email of expressions of interest, and hopefully there'll be some people out there that would fancy taking this on. And the candidates will then be selected by the BAUP EQA committee. We haven't decided the exacts of this yet. And hopefully we'll be in a position to announce some new people in time for the next participants meeting, which is in 2023. So possibly a bit of a bombshell, but I think we feel that it's probably right to be stepping away now and letting some new blood in and to develop the scheme further. There's one other issue just to flag, which is that for the first time in the scheme's history, someone has reached the second action point. And I think, John, you've been kind of dealing with the college in relation to this more than I have. So you can just kind of give us a brief summary of where we've got, because it's created some real issues in terms of the governance structure of the EQA schemes, not just Uropath, but the other schemes as well, and who is responsible for the oversight and investigation of performance.
Well, yeah, and basically the SOPs state that the Royal College of Pathologists, we refer it to the chair of the Professional Standards Committee. And when we did this in January, about 4 months later, they replied to us to say that it wasn't up to the chair of the professional to investigate this, and it was up for us to investigate it. And at this point, we contacted the chair of the NQAP, which is another committee which sits kind of with some organisers involved. And the chair has now taken it upon himself to do it, but it's caused other schemes to question why we have been submitting SOPs to the Royal College for the last 20 years, and the college have been signing these off. But actually, when we asked for them to do the job which they were signing off, they've decided that that's nothing to do with them, and they are just setting standards but not policing the standards. And I think that's where we've come unstuck to a certain degree. Because as organisers, I think we would find it very difficult to do the next step of we're not setting to investigate. So over the next 6 months, I'm sure the NQAP will sort out what we should be doing and taking this forward. So it's sort of watch this space, but there are some changes afoot, which will end up with changes in the SOP, which we will write into the SOP. This is, of course, independent of us deciding that it's time to hand off this the EQA scheme.
There is a comment, actually, John, maybe you could address about reminding people what the definition of the second action point is.
Oh, well, the second action point, you get a first action point if you become, you have a low score, which is less than 2.5%. 2.5% or 3%?
2.5%.
2.5%. So if you come in the bottom 2.5% out of the 2 of the last 3 circulations, you become a low scorer. You then receive a very nice letter from Dr. Mayer saying you are a low scorer. You would now need to attend. You now need to complete the next 3 circulations and not score low scores in order to avoid a second action point. But if you decide to not complete a circulation, you trigger a second action point. And that's what happened in this instance. The person did not contact us to say that they were withdrawing from the scheme. They just did not submit an answer. So they trigger the second action point at that point. So that's how you get the second action point. As I say, it's normally quite different. First action points are not uncommon. They do occur, but normally when we contact the person, they either pull their socks up and do very well for the next couple of circulations, or they admit that they don't do Uropath and they were doing it just for their own interest. And that's it. Nick.
Very good. So we'll just move on to remind you a date for the diary. The next BALP AGM and the next EQA meeting will be the 24th November in London. This will be an in-person meeting, and with some big hitters, Professor Jonathan Epstein and Arno van Leaders are going to be the guest external speakers at that one, so it should be good. That's John's renal tumour table that is very keen that everybody uses, and you're still looking for somebody for this.
Pathology
role.
portal, yes, please. Somebody who wants to do educator in GU for this thing. So please contact the pathology portal at rcpath.org.
Thanks to the secretaries and to Mick at KPMD for all their help, and your AI colleagues as well. So I think that is it.